very much, Colin, and it is fantastic that we have had so much interest in this conversation session on self-harm and suicide in older adults. As Colin's mentioned, this is a joint event between Yorkshire and the Humber Clinical Networks and the Office for Health Improvements and Disparities, and we've got people from both organisations supporting us on this call. I'm Fiona Gowdy, and I'm a clinical psychologist, and I'm the clinical associate for Yorkshire and Humber's clinical network for older people and dementia. So it's great to have so many of you on this call. I'm going to hand over very shortly to the first of our keynote speakers, Dr. Cathy Morgan. So Cathy is a research fellow at the University of Manchester. In the last 15 years, she's been working with large data sets and two big projects focusing on the epidemiology of self-harm in younger and older adults. And her work's been published in the BMJ and the Lancet, and there's been a lot of interest in that work. I heard Cathy speak last year and was very interested and energized to hear about her work, and I'm really looking forward to her kicking off our session, and then I'll come back and introduce you to our second speaker. So over to you, Cathy.
Okay. Great. So thank you for that introduction, Fiona. As Fiona said, I work on big data, looking at mental health research questions from an epidemiological and quantitative approach. Before I actually go on to give you an outline of the presentation, I just wanted to take this opportunity to say how mindful we are that any of us might be affected by suicide and self-harm. So I'm just going to share with you for a moment or two some support resources. So just at the start of my talk. Okay, so in this presentation, I'm going to be considering the importance of self-harm in older adults. I'll talk about the research gaps that we found before we embarked on the study, and also some the specifics of the study, how common self-harm is in older people, how it's managed in primary care, and also the mortality outcomes. I'll also talk about the considerations and implications from the work that I've just been involved in. Okay, so suicide is a major public health issue, and we know that taking into account any global differences, that it increases with age. And if we look at this data from ONS from 2019 registrations, we can see in this older age group that particularly males, the rates of suicide are on a par to the younger males. And we also know that self-harm is one of the most important risk factors for subsequent suicide. And unlike other age groups, people who self-harm have an increased suicidal intent in this older age group. And this was demonstrated from a study, a prospective study from 1997 to 2007 of individuals presenting at 3 emergency departments in large hospitals in the Northwest. And they found that although repetition rates were quite low in older age compared to middle age, that self-harm was more often fatal than in the older age group than in the middle age. So about 3.6% versus 3.3% in the middle age groups. So with this in mind, it's increasingly important to address self-harm in older adults, especially as we've got these projected populations set to rise in this age group by 25% by mid-2045. So we can see from this these pensionable age groups that by the mid-2045, there's this projected increase of 25%, which we don't see in other age groups. We also know that additional factors that older adults often face is declining functional disability, ability. They may have been involved in bereavement and also potential social isolation, which are all associated with self-harm among older adults. So when we looked at the research, the gaps in research, we found that there was limited published evidence on self-harm in this older age range. Most of it was based on hospital attendance, so we're relying on people actually attending hospitals, mortality statistics, and there was nothing based on primary care. So looking at more sort of the lower end of the self-harm. Also, the reports on the risk factors for self-harm was around repetition or suicide. They reported self-harm methods and suicide as a primary outcome. And because of the introduction of the NICE guidelines recommending older adults to be assessed by a psychiatric or mental health specialist that specialises in this older age group, we didn't really know what was happening with the specific clinical management because there were no previous studies around that. So this was a study we published. It was funded by the NIHR Greater Manchester Patient Safety Translational Research Centre. And I just wanted to draw your attention to my co-authors. It was a collaboration between Manchester University and Keele University. So our aims, therefore, were to look into how common self-harm was in older adults, using estimates of incidence for those aged over 65 years, how it's managed, so looking at referrals to psychiatric services, and also those medication prescriptions at 12 months following the initial self-harm. And then outcomes of self-harm, so looking at all cause and unnatural causes of death, including suicide. So the UK has this great resource, one of the largest anonymised primary care record database, the Clinical Practice Research Data Link. And at the time of the study, there was over 4 million active patient records, and it covers about 7% of the UK population. And it's generalizable to age, gender, and ethnicity within the UK. So at the time of the study, there were 674 registered practices, and 60% of those English practices were also part of a linkage scheme where we were able to access HES data, so hospital episode statistics, to see those consultations within secondary care, Office of National Statistics to gain some death registration details, and also indices of multiple deprivation, which is a proxy to social demographic and deprivation, which is based on patient postcode or the GP practice postcode. And it's based on 5 levels of those being less deprived to most deprived. And GP records capture symptoms, diagnosis, medication, all within read codes that are collected at the time of the consultation. So we extracted data on those aged 65 years and older, having an incident self-harm record between 2001 and 2014. And we use this self-harm definition by NICE of any act of self-poisoning or in self-injury, irrespective of motivation. So the codes we identified were from a spectrum of events, from the milder forms of non-suicidal behaviour to the near-fatal attempts of suicide. So how common? We found 4,124 self-harm incidents, which was an incident rate of 4 per person years. The rates within males and females were very similar, and the age, the older the age, the higher the incidence. So looking at the rate ratio, we found that the incidence was 30% higher within the age 75 to 84 compared to the younger age group of 65 to 74. and 80% higher among those for 85 and over. We also saw an increase in the incidence in the most deprived social economic status of a 20% higher incidence compared to the least deprived areas. So how is it managed? We found less than 12% of those were referred to mental health services, with more females to males referred. We also found that those in the most deprived areas were referred the least. And then looking at psychotropic medication, we found that females were prescribed psychiatric medication within 12 months of their self-harm, more often than males. And also the younger years, sorry, it's just hiding my thing. So in the younger years, there was less prescribing. Sorry, in the older years, there was less prescribing of the psychotropic medication. And looking at the types of psychotropic prescribing, we found that females, irrelevant of type, were prescribed more frequently. But more worryingly, there was this just under 12% of tricyclic antidepressants prescribed post self-harm incidents. And this is against NICE do not do recommendations. So looking at the outcomes and the mortality, we found that there were 908 deaths in the self-harm cohort and 2,454 in the comparison cohort. And when we looked at the mortality risk, we found those in the older adults who'd harmed themselves were almost 20 times more likely to die from an unnatural cause within the first 12 months, and 3 times more frequently in subsequent years. And although we only have found 48 suicides, for those people that self-harmed, there were 145 times greater risk to die by suicide following that self-harm. So in summary, among the older age population, we found a high risk of unnatural death, particularly suicide, low rates of referral, lower in more deprived areas, and higher rates of prescribing, including this tricyclic antidepressants. So I think we've highlighted the importance of self-harm risk in older people. We have to be mindful that the numbers and the study was based on primary care. So there will be underreporting with this age group, potentially reluctant to engage through stigma. And then there's different motivators of self-harm in older people, which I know we'll discuss in the next talk, and the importance of social and family support and connectivity. But I think we've highlighted the opportunity to gain both physical and mental health status when an older adult is consulting with any health condition for potentially early intervention, and that there's this necessity for careful prescribing and increased support when older individuals are consulting with self-harm. So just as an addition, the NICE guidelines were updated in September 2022, and there were specific relevance to older adults and self-harm. So paying particular attention to those with depression and cognitive impairment and ill health and frailty, and also an assessment to include the person's social and home situation and the potential for loneliness and isolation, and also recognising this high rates of suicide after an episode of self-harm. Okay, thank you for listening, and I'll hand you over to Isabella.
So thank you, Kathy. I think there are some very profound implications emerging from your presentation, and I think it will generate a number of questions. So I'm going to introduce Isabella, and I'd just like to ask people on the call to think about questions that they might want to ask and to put them in the chat, so that if you see a question in the chat, you think, yeah, absolutely want that asking, put a thumbs up by it so that we can begin to kind of collate questions for the discussion after Isabella has spoken. So let you be thinking about that. I'm going to introduce Dr. Isabella Troyer. Welcome, Isabella. She is a Government of Ireland Fellow at the School of Public Health, University College Cork, and also with the National Suicide Research Foundation. Over the last 5 years, she's conducted research examining self-harm in older adults with the aim of developing research to inform clinical practice policy and patient services. Currently, she leads a 2-year study, SURE. I'm sure Isabella will tell us what the acronym's for there. I've written it down but can't recall it, which examines individual and psychosocial determinants of self-harm in older adults to improve risk assessment and management of self-harm in later life, and that's funded by the Irish Research Council. So over to you, Isabella.
Thanks a million for the introduction, Fiona. I'll just share my slides there. Everyone can let me know when they can see them. Can everyone see that okay?
Yep, can see that. Yep.
Yes,
Perfect.
thanks.
Thanks a million. So thank you for the introduction, Fiona, and it's great to be here. Thank you for the invitation, Colin and colleagues. And for the great introduction from Kathy, because she really did set up the scene for my presentation. So I'll be talking to you about self-harm in older adults, and this will be an evidence review, and it'll be a whistle tour stop on research that I conducted as part of my PhD back in the UK. I'm currently based in Ireland, as Fiona mentioned. But this is research that I conducted in the UK in Keele University. So just an overview. We're going to be looking at a systematic review that was published, that we published on self-harm in older adults. Then the majority of the rest of the focus of the talk is going to be on qualitative work that I conducted as part of the PhD, which was why do older people self-harm, and where do older adults access care and support, and barriers and facilitators for accessing care. So quite relevant for the audience, I think, and hopefully you'll be able to take a few home messages. So as I said, this is based on 3 different papers or studies, and just to sort of rate, I think it was mentioned that, or I think, yeah, that we'll be sharing the slides. So any of the information that isn't, that you don't manage to write down or whatever, you'll have the slides with you and you can find the studies there as well. So the first study was a systematic review looking at the characteristics of self-harm in older adults, and a systematic review basically aims to look at the published literature that has been there in internationally, so globally, so not just looking at England or Ireland, but just in what there has been published internationally. And specifically, I was looking at the characteristics of self-harm in older adults. So we found 40 studies across different countries globally, and out of these studies, there were just over 63,000 self-harm presentations with just over 62,000 participants. The majority were women, and the ethnicity of the majority of participants were white. In terms of marital status, just over half of participants were not married, so either widow, divorced, single, or separated, and 40% of participants were living alone. I think Kathy mentioned how the older age group tends to have higher suicide risk, and just to mention that in this study, the majority of participants were, even though the age range was from 60 to 112 years old, but the majority, so 60%, were considered younger older adults, so aged between 60 and 74 years old. And there was a wide representation of countries that were from where these were published, but the majority of the evidence came from high income and English countries. So most of the studies were from the UK, the US, Australia and New Zealand, but also representation from these other countries like Israel, Brazil, France, and more. So we want to look at rates of self-harm and presentations, and these varied between the different studies. In the US, this varied from 19.3 per 100,000, and in the UK, 65 per 100,000. We also looked at the self-harm method that was used by older adults when they presented with self-harm, and intentional drug overdose was in the majority of the cases just over 86%. So this is something worth thinking of as well. In terms of previous psychiatric and medical history, just under a third had previously reported that they had self-harmed. The majority had a previous psychiatric diagnosis, with the most common being depression. Over a third of participants were taking antidepressants or prescribed antidepressants, and 38% reported a comorbid physical illness, and with the majority of participants reporting pain and chronic illness. And alcohol use at the time of the self-harm presentation was just over 15%. In terms of contact with healthcare services, 62% of participants had seen their GP within the last month, and 40% had received psychiatric services in the past, while 28% were currently receiving psychiatric services. We identified risk factors for self-harm repetition, and these were social demographic and clinical. Being female, not being married or partnered, being not currently living alone, and being a younger or older adult, so age 60 to 74, were some of the social demographic characteristics for risk factors for self-harm repetition. And in terms of clinical characteristics, current or previous psychiatric diagnosis, previous history of self-harm, and alcohol or substance misuse placed older adults at higher risk of self-harm repetition. So just concluding, some of the take-home messages from the systematic review is we know from international and national clinical guidance the importance of managing and identifying older adults who self-harm because of the increased risk of repetition and suicide. And although the study didn't make a comparison with younger adults, we did see that there was increased suicidal intent, comorbidities, and access to means with the medication that and prescribing medication with comorbid physical illness. And it really was an opportunity for prevention within the healthcare services, and particularly primary care, because of the high rates of people having seen their GP within the last month. So the next part of my research is the qualitative study that I was mentioning, and here I'll present two studies, one that looked at the motivations for self-harm, and with this, I'll just talk through you a bit of the methods. So we conducted in-depth semi-structured interviews, which are either over the phone or face-to-face, with two different participant groups, so older adults age 60 and older with self-harm behavior, as well as third sector support workers who were working with either mental health charities or older adults charities. And recruitment was conducted in England. We conducted just over 24 interviews with 9 older adults and 7 support workers. And the age range, again, we captured just the majority were younger, older adults, as we can see here. So the mean age was 63.8 years. Most participants were female, and all of them had reported that they had a comorbid chronic health condition. So I'm going to present the findings with the research question in mind, which was, what are the motivations of self-harm behavior in older adults? But the first thing that I want to sort of come across as the first take-home message was that self-harm was experienced throughout the different stages of the life course. So some participants had identified self-harm, had mentioned self-harm starting in their early teens, while some and it continued into their mid-adulthood years, while some started to self-harm later in life. There were different stressors that older adults identified as contributing to their self-harm behavior, and these varied from factors such as loss, bereavement, or loneliness. So either being bereavement from a partner, or loss of a job, or experiencing loneliness, as well as interpersonal problems with or comorbid health problems. So these different stressors really contributed to self-harm behavior in older adults. And there were different functions that older adults identified for their self-harm and how they described that their self-harm served different functions. And I'll talk a bit more about this in this model that we conceptualized based on the motivations. So I'd like to draw your attention to the spectrum here. So usually self-harm in older adults is associated with attempted suicide or high intent of suicidal intent. But older adults identified that their self-harm could be within a spectrum of no suicidal intent to high levels of suicidal intent. And older adults identified that initially their self-harm started as a cry for help. I know usually the term cry for help can be seen negatively, but the way that it was described was it was a way for them to ask for help. And there were different functions within self-harm that they identified. So it was identified as a coping mechanism, as numbing pain, to escape reality, sometimes even to avoid suicidal behavior, or sometimes to express intense emotions and deal with previous traumatic events. So I was mentioning to you about how they had expressed suicidal intent and no suicidal intent. The next slide is going to have just a few quotes from participants. And just so you know, the names have been changed. And so, yeah. So we can see in this participant, for her, she didn't really see it as suicidal. It was more of a cry for help. But she did identify a few occasions where it was to kill herself. But for her, really, it's as a soothing blanket, as it's mentioned here, where it gives her comfort that for her, she wasn't receiving from other people. And then other older adults had identified different stages of their life course where they used self-harm with different functions. So here there's a quote saying that, when he was younger, it was about, ending his life. But as an adult, this sort of change and the relationship and the behind self-harm and the intent also changed. So the last bit of my work is looking at accessing support. Where do older adults get support? And we wanted to identify the different sources of support that older adults get. And this would be from the formal sector and the informal sector. So older adults mentioned health sector, primary care, secondary care, third sector as well. But also the informal sector was an important source of support with family and friends, peers, faith, and the internet. There were certain help decision factors that were identified. So even though older adults had experienced self-harm throughout different stages of their life course, it was often hidden from months to years and even decades. And this was often due to shame and stigma, which I'll mention in the next few slides. So you'll see how this had a profound impact on how it was really stopping older adults from seeking support for their self-harm. So there were different barriers to accessing support that we identified, but overall stigma was present throughout. There were external factors such as healthcare professionals' attitudes and preconceptions, as well as the structure of the healthcare system. There was also this view of fragmented care, where older adults reported that there was a lot of focus in their physical health conditions, but and their mental health was separated, and it wasn't really as they were seen as an overall patient in that sense. There are also practical barriers, so mobility restrictions, transportation difficulties, limited resources and staff, and also internal factors. So we'll see in the next few slides how even older adults felt reluctance to seek help, and their own attitudes and preconceptions also affected them seeking help. And sometimes the own health status of older adults, so if they had a deteriorating health status because of a certain health condition, that also affected them seeking help because they were focusing on improving on the condition. So we can see here in the two different slides that there was shame and stigma that was identified by participants, and this was both internal shame, so like what they felt. So for instance, we can see this quote that says, I felt embarrassed, and they didn't want to ask for help because they're thinking, this is something that teenage girls do, not me, who I'm in my 60s. while there was also views that older adults, that healthcare professionals would dismiss their problems and that they're not taken, it's not taken seriously. So that was also identified. Lastly, there were certain facilitators to accessing care that were identified. So external factors such as positive attitudes and empathy, stuff with previous experience. There are also structural facilitators, accessible facilities, provision of ongoing and regular support, as well as previous treatment, positive treatment experiences. But an overall reduced stigma would be something that would have was identified as a facilitator. So just to conclude on the talk for today, older adults who self-harm may have comorbid and complex health conditions, which often result in contact with the healthcare services, in particular primary care. However, help seeking is often delayed due to stigma and shame. But clinicians should be aware of the heightened risk of self-harm in this age group, so adequate support, with whether it's referral or within primary care, is provided. And yeah, really identifying, because older adults quite frequently contact primary care, that this could be a good opportunity for that. So yeah, that's my research. And if you want to look at some of the resources, we also developed different information leaflets and box recommendations for GPs, for instance, working with older people who self-harm. So you can get these all through the sites. But yeah, that's me. Thanks a million.
Thank you very much, Isabella, and thank you both. I think both of those presentations dovetail perfectly with the what around this topic area, and then some of the why. So I've been frantically monitoring the chat as we have been going through, and I know my colleagues have. So there's a question from Leila Mehdi asking, where does self-neglect fit in? So I wonder if you'd like to respond to that. And I've got there's another 3 that I've noted, so I'll try and manage the time and the questions, and hope that other questions we'll have time for too. So we've got until 1. So any thoughts on where self-neglect fits in, either Kathy or Isabella?
Yeah, from the study sort of capturing those sort of events, I mean, it's a really good question. And self-neglect and eating behavior as well. Within the patient record, that wouldn't necessarily be coded very well, so it wouldn't be something quantitatively from the data that I'd be able to pick out, but certainly it is a big consideration. So I don't know whether Isabella has any comments
any
on
thoughts,
that.
Isabella?
Yeah, thanks, Kathy. So I suppose, like in all research, we sort of predefine our limits. So we looked at self-harm with the NICE guidelines definition. So again, any irrespective of suicidal intent, of harming yourself. So self-neglect wouldn't really fit within those guidelines. But I think it is a consideration for future thinking of the older adults population, because it would be totally different to a younger adults population. I think, in my own opinion, in the sense of the role that self-neglect can have, particularly not eating, not taking their medication, that would, I remember there was one participant who, so she was diabetic, and she would, deliberately, she's like, I know I'm harming myself by eating whatever it was, sweets, or, so there is, I think, in a way, different behaviors that don't fit within the definitions of self-harm that we use, but also self-neglect, like that would like not taking medication or not eating, which are important, but we didn't unfortunately see it with our study.
Okay, thank you. There's another question with I think a couple of people have posed a question on the theme of tricyclics. So just wanting to clarify, so there's a clarifying question about have people read the findings correctly, that as suicide rates become higher as age increases and psychotropic medication decreases. Is that a correct reading? So I think that was a clarifying question. But to take that further, there's a specific question on, could the tricyclics be for pain? Might not be, you know, kind of in line with the NICE guidelines, but possibly understandable. Have you got any responses just to confirm that reading? I think this would be to Kathy particularly, and do either of you have any thoughts on tricyclics? Is that around pain, and in which case, you know, might there be some thoughts about implications there?
Yeah, so we definitely saw the increased suicide rates on age and the prescribing of antidepressants. As regards the tricyclics and any antidepressants, it wasn't that those were prescribed with the link to the self-harm event, so they could be prescribed for any condition in that sense. We could potentially unpack that with certain other codes, but we did just look at antidepressants and then noted this quite high rate of prescribing when it's against the do not do recommendations, regardless of what it's being prescribed for. So we were quite shocked by that. So I think, does that answer your question?
Well, I'm nodding myself because I'm just reading what it said, what the question was in the chat. Yeah, I think the clarifying does, and I think what you've said about, you know, you've actually clarified further what the you know, the point about tricyclics not being given for self-harm specifically, but there are kind of there's further thoughts. So just to sort of carry on, there were a few questions in the chat about comorbidities, so on the topic of comorbidities more generally. So do you have any information on the numbers and types of comorbidities? And then people have come up with, what about alcohol, what about dementia? So there are a number of questions about comorbidities generally, and so I think there are one or two which have asked about generally, and then others have said anything specific on dementia, anything specific on alcohol. So your thoughts on comorbidities? I think Colin's nodding. I think that I'm hoping I've kind of covered that one off with its with the broad, in its broadest sense, that question.
So within the paper, we actually looked at comorbidities both from more sort of mental health and also other health conditions, and we actually just gave proportions of those that were in the record, the electronic record, pre the self-harm and also post self-harm. So these were new episodes, and within the and this was separated into those with self-harm and those in the comparison cohort. In terms, so the comorbidities for health conditions included cancer, cerebrovascular disease, chronic pulmonary disease, congestive heart disease, diabetes. There was myocardial infarction, there was renal disease. Now, I thought we did do dementia. I may have put that somewhere else within the paper, unless I put that under mental health. So I'm just trying to find the paper to sort of see within the paper. So it wasn't really necessarily looking at the direct risk and how that relates to the comorbidity. It was more to look at the prevalence of it or the incidence of it pre self-harm and post self-harm, just to get a feel for any comorbidity.
Yeah, just to add to Kathy's point on comorbidities, I think so in the systematic review, so you know, the international review of the evidence, there were I think it was just over a third of participants that had reported comorbid health conditions, I think CVD, so cardiovascular disease, was the most common. And then in the qualitative work, obviously, we're not talking here about prevalence or trying to, it was more about the impact that comorbidities had. And I think that was quite important in terms of both for motivation. So there, like, I remember there was an example of someone who had worked until their mid-50s. They developed a health condition and they were generally healthy. They didn't have problems with their mental health before. And then upon developing this condition, this health condition, they lost their job, and this was just a spiral of going downward, and it started with their self-harm behavior. So I think it is something to consider quite a lot in older adults as well, in terms of like motivations, but also like accessing care and support. So a lot of the participants had reported, as I mentioned in the presentation, you know, how sometimes we know that consultations, if they're seeing a general practitioner, for instance, they're limited time, and if they're going because they have different health conditions, different problems, it's hard to prioritize one over the other. And usually, what tended to happen was that self-harm, or you know, the mental health, tended to be put aside in that sense. So it was something that was quite present. I think it's really worth considering when we think about the older adults population.
Thank you. Colin, I've kind of prioritized the questions in the early part of the chat, but not the latter, the ones kind of later on. So is there anything you want to pull out and prioritize questions wise?
There's a couple that there's quite a few actually. There's probably another 4 or 5 questions to go
Okay.
up, but
Okay.
there's one question around from Gerard around did you find any urban/rural differences in your research?
So that's something we weren't able to look at that level, only through social deprivation, really, which isn't the same. So no, we weren't able to look at that in this particular data set.
Same, unfortunately, similar to ours, it wasn't something that was looked at.
Okay. I've got some more. There's a question directly to you, Isabella, from Claire. She asks why in your study you used the cutoff of 60 for older adults rather than over 65s.
Yeah, and it's something that, thanks for that question, it's something that's very hard to define. And even when having discussions with my own dad, because I work in this area, he'd be like, 60 is not an older adult, Isabella. I took the WHO definition at the time, so that's why I included 60 and older. But I do think we need to consider we do living in an aging world where we're living longer, healthier, and you know that might have to be reconsidered, especially as well. Being 60 in the UK is not the same as being 60 in another part of the world. So I think it's something also worth considering and worth exploring. But yeah, I just took the WHO definition, so that's fine.
Okay, thank you. Okay, moving on. I've got one from. This one is, do you have an explanation for the reduced referral rates to mental health services depending on an observed demographic? Is this about GP referral itself or about compliance by the patient?
So the referrals were based on a code that appears in the GP record to mental health services. So in terms of reduced referral rates, depending on observed demographics, so you mean sort of within younger older adults and the demographic, as in the social deprivation variable. So yeah, we looked at those referral rates within those groups.
Okay. Did you want to add anything to that, Isabella? You're on mute.
sorry, it wasn't something that we explored. So no, we didn't have data on that.
Okay. There's another question about this is directed to you, Isabella. Was there any impact, Isabella, on culture or religious beliefs on suicide, self-harm in your study, which had an international sample?
Not on the international sample, no. It wasn't something that was identified or that was measured, really. But there has been other research that has had a look at, the role of, different cultures, also religions and social cultural factors that impact in older adults, but it wasn't in the international sample. And then in the qualitative work that I did, unfortunately, we struggled quite a bit to recruit from non-white participants. So I think I can't remember if I put it there, but we had something like 90% of participants were from a white ethnicity. So I think that obviously has quite a bit of implications in terms of generalizing the findings with other different social cultural groups.
Thank you. I can see a question about assessment tools. That are there any specific risk assessment tools developed for assessing risk in older adults? Controversial topic. So maybe your responses on that, and there may be others that want to chip in on that one as well.
I don't know of any specific assessment tools, but I know it's not recommended for self-harm to do any sort of assessment tool, full stop. I do know the guidelines do have lots and lots of information in terms of safety plans and assessments, but no specific tools are available.
I think the clinicians on the call will be very pleased to hear you say that, to remind us of the NICE guideline that in fact, risk assessment tools are not recommended, and it is about producing safety plans and taking that person-centered approach, and that's where the evidence base lies. So it is perhaps just worth. I'm glad you've said that. I don't know if you want to add anything, Maria.
No, I'm good, Fiona. I think you covered that.
Yeah. Okay. Anything else? I think. Just to reiterate, those of you that have continued to ask for slides, if you've logged on, you'll be getting the slides, and we'll make sure you have the recording. So cover that one off. I think some people. I think there was a question about any data on psychological recovery for older adults. I don't know if either of you want to comment on that. And again, I think there will be people on this call who know quite a bit about that kind of, but give you the chance to go first on it.
I wouldn't know, to be honest. I mean, I know certainly from a GP record point of view, we don't get any sort of resolution codes, so we don't know how long a condition proceeds. So that's really quite tricky to look at in this sort of data anyway.
Yeah, of course. Yeah, Maria, any?
Nothing specific on older adults, but I was just thinking of the research that is out there, and there's quite a few people who have looked at the psychological therapies for adults, and usually there's some evidence for CBT, but it's not for repeating self-harm, but like it wouldn't be specific for older adults, but that's the evidence that there is out there, and there's a few studies I'm happy to point out to people that have summarized that recently.
If you could maybe let us have them,
we
can send them rather than people requesting it in the chat. We'll make sure it's sort of circulated. Yeah, I think there will be others on the call who are well steeped in older adult psychological therapies outcome data, and I certainly know that IAPT has a very large kind of publication and CBT has a considerable publication record in this area, not in relation to suicide, but certainly in relation to good outcomes for older adults in therapeutic interventions once they have gained access. So it's the access that's the issue, not the outcome. But there are others probably on this call that can post responses. Anything else, Colin?
We've got Denise has got a hand up.
Great. Sorry, I'm looking at the chat, not the hands. So thank you so much. Yeah, come in, Denise.
Yeah, sorry. So I've just put my hand up because there were a couple of questions that I've picked up that have not been covered. Peter Hodgkins has just posted his question again. He said he was wondering about the link between recent bereavement and self-harm suicide. From his own practice, he's seen the recent loss of a partner being a trigger for suicide attempt a number of times, and this could perhaps be reflected in the higher incidence as age increases. Was this looked at all?
Okay, well, to try and capture bereavement in a GP record is quite tricky as well, because that may go into free text, which we don't get access to. So it won't be recorded routinely. So we weren't able to look at that. But it's a good point that, that is one of the risk factors in terms of being exposed to bereavement, experience bereavement.
Yeah, to Kathy, so like both in the systematic review based on the public, that was one of the risk factors identified, so a recent loss bereavement, and then in the qualitative work, it was also identified as recent bereavement of a spouse. So yeah, it was something that I didn't go into detail during the but you can find them in the papers, but it is something that was mentioned as important.
Okay, thank you.
Thank you.
There's another one as well. Have you noted any cultural differences in self-harm behaviours? Like, for example, Asian families, children live with parents or they stay jointly, which can potentially offer protection with social isolation?
I haven't conducted any research on that, and that's quite a big area, I think, to explore, as there's a few protective factors that are identified there. So like living with others. I haven't done any work on this, but yeah, it's definitely something worth that exploring.
Okay, thank you. And there's one more that I've picked up, which was a comeback on, I think, what you were saying, Isabella, earlier. I know you mentioned you weren't able to measure urban and rural differences. Were there any results regarding socioeconomic status and any observed differences there?
No, unfortunately not. The current work that I'm doing in Ireland, we will be looking at that, and hopefully it'll be, but not in the work that I report, unfortunately, no.
Okay.
Which is important, I know. Yeah.
Okay, thank you.
Thank you.
Thanks, Denise.
I'm just seeing that there's also some, so thank you for sharing the psychosocial interventions for self-harm reference, and I can see that there have been a couple of other shares, so an offer to share dissertation on alcohol, substance misuse, and Colin, yes, you've posted some nice guidelines, so there are a few shares on the
these shares that I've just posted are from Kathy, actually. That's what you sent through to me, Kathy. So
brilliant. So we've got some
good links there.
We've got some good links that we have put in the chat. So are there any other questions that we might do we think that by and large, Colin, we've covered most of the themes, most of the key questions, given that we have about 3 minutes left?
Yes, I think I mean, as far as I can see, we've covered them, unless any of our colleagues can see any that we haven't, and unless anybody's got a last minute question they want to put their hand up and come in and ask.
So we've had lots of thanks, lots of it's fascinating presentation, and I think certainly generated a huge amount of interest. I don't know how many we've had on the call, but certainly I think this is a topic that's certainly of interest, you know, from the practitioner to the public health and prevention and across primary, secondary and voluntary sector partners. So thank you both so much. Thank you to my colleagues at Yorkshire and Humber Clinical Network, Colin and Denise, for supporting and coordinating, and it's been a great session, and thank you all for joining, and it's been a pleasure to engage with this really interesting topic. Thank you, everyone.
Thanks, Fiona. Can I just say a big thank you to our colleagues in the Office for Health Intelligence and Disparities as well, OHID, who helped to put this session on, and a big thanks to Kathy and Isabella. And yeah, we will send the recording out and make sure that everybody gets the link and the slides as well. Thank you all.
Thank you. Enjoy your afternoons.